I think we've come up with a very nice and important comprehensive set of elements that constitute good survivorship care. And I refer back again to the IOM report, which for me is sort of the Bible that's still tried and true and very useful, that really highlighted these elements. And we've moved away from that bullet number 1, surveillance for recurrence of the primary malignancy, as being the one and only thing that we look at, understand, and deal with, in particular when the patient is in our clinic, in our exam rooms. But really looking at long-term and late effects, medical and psychosocial, that was highlighted this morning, how important these things can be. And a survey that was done a number of years ago by the Livestrong Foundation found that the psychosocial issues weighed more heavily for the cancer survivor and their family than did the medical issues. Screening guidelines are very, very important. Health education about issues and the availability of community services. Most of cancer survivors in this country with adult onset cancers are treated in the community, not at academic medical centers like mine. And so this becomes very, very important about how do you connect the dots and link people to available resources that may already exist and that you don't need to build again. Health promotion is critically important, including smoking cessation, diet, and exercise. And I think diet and exercise, we have more and more evidence about its value. Diagnosis and treatment for cancer is a teachable moment, not only for the patient, but also for family members and friends who may continue to smoke. We'll talk a lot, members of the panel today, on the treatment summary and care plan and how its utilization, the barriers, the challenges, and also the opportunities, which then become the communication tool often with the community physician. And because of the group that you are today, and I think this is important throughout the country, even at the not just the national but local level, is how do we empower survivors to advocate for their own health care needs in the particular individual and family arena, as well as the kinds of things you're doing. So I show you this slide, this diagram from a paper that was published in the Journal of Clinical Oncology in 2013 by Perry, because I think it actually sets the care plan in its proper perspective, and that it is a core element for sure that relates to models of care, the processes of care, how we provide it, and you'll hear about the technology platforms that are both facilitating and I think also become obstacles for our ability to do this for the large number of individuals who need these care plans. But again, it's a tool for care communication, coordination and communication, and it helps with the kinds of things that are listed under adherence and management, how we use our healthcare resources in an efficient way, and what can be the effects on the organization in having this care planning be seamless. Ultimately, the output should be really outcomes that relate to the benefit of the patient at the top, and then looking at the costs because the healthcare system is a financial mechanism, and we do need to look at, and payers will be looking at whether they're public and private, of whether they're getting value. So in thinking about care planning, one of the things that we heard a little bit about this morning, and I'll spend some time on in my presentation, on models of survivorship care delivery. One of the certainly the tried and true traditional method of doing this is oncologist specialist care, but I think that we're really seeing many more models that evolve that really relate to not only the community where care is provided, but also the patient population and the availability of providers and their education and training. The multidisciplinary clinic is also very well known. It is the pediatric model that is utilized for, I think, intensive services and very appropriate in that population, but isn't necessarily needed for patients with all patients with adult onset cancer, but may be very appropriate in a bone marrow transplant clinic. Very often, those of us who were and are starting survivorship programs and clinics start with a disease-specific clinic. It's a group of early adapters, people that wanted to work. You heard about one this morning, a lymphoma clinic. There was a champion for that group of patients in that clinic, in that major cancer center. So you start where you can begin, and you start with people that want to work with you to make it successful. There are general clinics evolving around the country because they're not disease-specific. They don't have a population large enough, especially in the community. And you heard also about a consultative clinic, a one-time visit to pull that care plan together to make a difference and do something different so that there is something going forward for the patient to have, as well as the primary care physician in the community to use and learn from. Integrated clinics that are part of the delivery of care. Also, the community generous clinic. It doesn't happen as often in this country, but in other countries it's quite common where the PCP becomes the provider of survivorship care very early on. But that implies an educated as well as a large workforce of primary care physicians. And then I'll talk a little bit about our own effort, which is a shared care model of survivorship care, using a nurse practitioner and physician assistant as the providers of survivorship, but also pairing with a primary care physician. So also thinking about in the community, and you may hear more about this later today, but it's really the community where it all happens. And so we need to think about coordination among the oncologists, the hospitals, and in primary care. How do these three groups work together in complementary roles, and who takes responsibility for what? So this becomes important, not only the surveillance combined with the general medical care, education, and then the care plan delivery as well. So I just show you this slide because it's not a comprehensive list of everything that's been published, but to just show you there have been evaluations of models of care, but they've really been trickling in little by little, as you can see, over time. And we really do need to evaluate more completely, not just in terms of the outcomes from a medical perspective, but also from the perspective of those individuals that are involved in that care and their families. And so we have a lot of research to do in this regard about what are the optimal types of models of care. And I agree with the speaker from this morning, there isn't going to be one size fits all. It depends on your geographic location, the availability of resources, and also the treatments that patients had. So the providers of care actually do drive the models of care in many respects. And to think about who should be the provider, you want to know what the types of services that you want to initiate and provide. It may be that in a community that the hospital is going to provide psychosocial services because the oncologists do want to keep the patients for their long-term follow-up. So that becomes a win-win for people. They're not competing with each other, and for the patient and family, there are added opportunities to have better care going forward. And to think about a rehabilitation focus, maybe even partnering with a local gym that the hospital may do, that the cancer center may do, that there's a lot of unique and I think innovative ways to think about comprehensive survivorship care. Thinking about the timing of the services, whether it's immediately after treatment, there's a short delay when it begins, that it's actually a one-time visit or ongoing care. All of those are important questions to ask in setting up your plans. So I'm going to talk a little bit about our own efforts at my institution, where we started about 13 years ago to develop a survivorship program, which now has turned into a formal survivorship center. And we honestly didn't know what we were doing because we had no prototype. And so we spent a lot of time talking about who would be the appropriate provider of care. Should we use our pediatric model that had been there and available and functioning very, very well and very sophisticated for decades? But for our adult onset patients, what would they need and how should we do it? And we talked initially to our patients who said, when we thought, well, we'll have this survivorship clinic at some other place, and they said, well, you don't think you're going to take me away from the physician who cured me, do you? And I thought, oh, this isn't going well. And so then I talked to the patients, or the physicians and the nurses who had treated these patients and said, and what do you think about having this very nice clinic at 53rd Street? And they said, you don't really think you're going to take away the highlight of my day, do you? Somebody coming in and talking about their grandchildren or getting married. And I thought, this is getting worse than I thought. So what we did after spending, I'd say, 6 to 8 months having discussions with a steering committee that included patients is decide that a nurse practitioner PA model of care was what we really should do, that these were individuals that were really focused on wellness and rehabilitation, and that they could and would be the providers, and so they would be embedded with the clinical team. So from the patient's perspective, it's the right provider at the right time. And I'm not suggesting this is the only way to do it. I'm suggesting there's a process to think about in your own location, with your own community. How might it work in a way that people will accept it and work with you to make it successful? So that's how we started, and this diagram shows you that the oncologist would transition patients at a predetermined time to a set of nurse practitioners who would then make sure that there was a PCP involved, because sometimes patients don't have a PCP after cancer treatment. And so we had to reinitiate those relationships if they weren't ongoing, and assure that that happened, and then reinstitute a communication on an ongoing basis as well. So we had a lot of work to do in terms of changing culture in how people practiced. Plenty of physicians actually were unfamiliar with nurse practitioners at the time. And what we realized is that we were just moving patients from one provider to another, but we really didn't have a long-term plan for how this would go. And so my colleague Kevin Evinger, who is actually the Survivorship Center director, and myself spent a lot of time thinking about how we should do this in terms of a risk-based plan of care. You heard a lot about exposures and who's at risk for particular kinds of problems after cancer treatment, but not all survivors are at risk for every single thing and are not as likely to get one thing as the next person is. And so to think about low-risk patients, medium-risk patients, and high-risk patients. So we began to really think about who needs to be with us and for how long and what services do they need. So we began to parse out this difference in survivorship communities and populations. And we have a very, very large cancer center, so we're able to really think along population groupings and rethink how we do survivorship care. So what we did was realize that there were individuals that at low risk of problems, low risk of late effects, low risk of recurrence after a certain period of time. And so that we, with good preparation, could transition them back. And again, we're going back to this idea of transitions. First, there was a transition to the nurse practitioner within the team, and then a transition, if things were going well, to the primary care physician. And that has been, and I'll show you some data, that has been a real challenge for a number of reasons. And I think that's, for many of us that have been working in the survivorship arena for quite some time, this is our next big and important challenge, especially as the healthcare system is changing right under our feet. So what we do now for many of our clinics, as you can see here, is transition back to the community physician, who, when I say back, isn't probably the right word, because we try to engage the primary care physician all along.